Now we will discuss what can and cannot be delegated to the PTA. First, however, I need to explain in no uncertain terms that the physical therapist is directly responsible for the actions of the physical therapist assistant. So, for example, if a patient is injured while working with a PTA, the PT is ultimately responsible. To be clear, the PTA may be liable for their legal actions, but the physical therapist will be as well, as they are the supervisor. It is crucial that you understand your role and practice within the boundaries of that role. Now moving on, what can be delegated to a PTA? Well, first we have tests and measures. These techniques include range of motion assessment, manual muscle testing, vital signs assessment, and tests such as these. These are to be used in the intervention component of the patient-client management model. So, for example, let's say you are seeing a patient with a total knee replacement. You could take a range of motion measurement prior to your treatment session and one at the end of the treatment session to determine if progress was made. These techniques are not meant to be used by the PTA during the examination or re-examination processes of the patient-client management model, but rather the PT is responsible to perform these techniques. PTAs may also perform direct interventions, which we spoke of previously. These include things like therapeutic exercise and functional activities. To further clarify your role in the plan of care as it relates to interventions, be very clear on the following points. All PTA activities must be as directed, prescribed by the supervising physical therapist. The PTA may modify a treatment plan, but only after approval by a supervising physical therapist. And third, the PTA may modify an existing intervention already in the plan of care. What does this mean as it relates to the plan of care? What this means is that if a PTA wants to add a new intervention that wasn't originally documented in the plan of care by the physical therapist, they have to get permission to do so. So, for example, if a PTA thought a patient would benefit from an ultrasound treatment, but this is not in the original plan of care, they would have to get permission by the supervising physical therapist. If, however, there was an intervention already documented in the plan of care, such as lower extremity strengthening exercises, the PTA may modify the exercises that are already within the plan of care as they see fit. So please be very clear on these 3 points. Now let's look at what cannot be delegated to the PTA. To begin, interpretation of referrals when available. If a referral is made to PT, it will contain a diagnosis and an order, usually to evaluate and treat. The PT must decide on the referral. Second is the initial examination, evaluation, diagnosis, and prognosis, and development or modification of a plan of care, as we discussed with the patient-client management model. As well, only the PT can determine when the expertise and decision-making capability of the physical therapist requires the physical therapist to personally render physical therapy interventions and when it may be appropriate to utilize the physical therapist assistant. Also, as previously discussed, re-examination of the patient and establishment of discharge plan and documentation of discharge status can only be performed by the PT. And finally, oversight of all documentation for services rendered to each patient is the responsibility of the physical therapist. Please review this slide carefully so you understand your roles and responsibilities. Now, if I were to ask, When a PT is deciding whether or not to delegate interventions to a PTA, what factors do you think that the PT considers? Well, one factor is supervision. Supervision must be available either on-site or off-site, dependent on the State Practice Act. Also, the PTA must be comfortable in asking for supervision. This is a partnership between the PT and PTA. Another factor is education. What educational preparation does the PTA have in addition to the general PTA education? For example, do they have a specialty certification in aquatherapy? This may be considered by the PT in deciding what to delegate. Another factor is experience. The PTA may have learned new techniques after graduation and also had experience in a particular practice setting. Another factor is state regulation. The licensure rules can also dictate the duties and responsibility. So, for example, I mentioned this in an earlier lecture, the PT to PTA ratio. If a PTA is already supervising 3 PTAs, they may not be able to delegate to a 4th based on state law. Another factor is the organizational structure of the PT service. In all these cases, the PT is ultimately responsible for all aspects of the patient care. The APTA also defines delegation and factors that a PTA may consider when delegating to a PTA. The first is complexity and acuity of the patient's needs. So, for example, if a patient is very stable, a PT may feel comfortable in delegating duties to the PTA. However, if the patient's condition is rapidly fluctuating, the PTA may want to perform all the treatments. In addition, proximity and accessibility to the physical therapist is examined, as well as supervision available in the event of emergency situations. And finally, the type of setting in which the service is provided is included in a PT's rationale for delegating duties. Also, to clarify your role in various practice settings, the APTA defines the levels of supervision required, and Medicare has similar standards. First is general supervision. In this case, the physical therapist is not required to be on site for direction and supervision, but must be available at least by telecommunications. The next is direct supervision. In this case, the physical therapist is physically present and immediately available for direction and supervision. The physical therapist will have direct contact with the patient-client during each visit that is defined in the Guide to Physical Therapist Practice as all encounters with a patient-client in a 24-hour period. Telecommunications does not meet the requirement of direct supervision. And finally, we have direct personal supervision. The physical therapist, or where allowable by law, the physical therapist assistant, is physically present and immediately available to direct and supervise tasks that are related to patient-client management. The direction and supervision is continuous throughout the time these tasks are performed. Telecommunications does not meet the requirement of all direct personal supervision. To note, all student physical therapist assistants must practice under at least direct supervision. So an example of general supervision would be a physical therapist assistant in home health working in someone's home, and they have telecommunication capabilities with a PT at a distant location. An example of direct supervision is a physical therapist assistant working in a hospital in which they may be treating patients on a different floor than the PT, but the PT is physically present and immediately able to get to that person if need be. However, they don't need to be in the same room. Then an example of direct personal supervision is when the PT must be present with the PTA or student PTA while they are treating patients. So they need to be in the same room. Another support personnel common to some practice settings are PT aides or techs. These are non-licensed, on-the-job trained individuals that are found in some practice settings. Rules for delegation to these team members is defined as: the aide may perform physical therapist directed services. Physical therapist directed services include treatment room preparation, cleaning of equipment, and transferring patients for treatment. The PT is ultimately responsible, and direct personal supervision is required. PT aides should not conduct any direct patient care activities. Now let's discuss informed consent. What sequence of events must happen before an injured or diseased person can be treated in a physical therapy setting? You have almost likely signed a document consenting to treatment, but what are the true requirements for informed consent? Well, first, consent must be obtained before treatment commences. An example of this is when you sign the document prior to a physician visit. Informed consent should include the following components: a lay description of the treatment, meaning describing the treatment to the patient in terminology that they can understand. Also, the associated risks should be described, as well as the expected benefits of the treatment and alternatives to the recommended treatment. These 4 elements are required for true informed consent. Prior to direct access, there must have been a referral by a physician, and it was dependent on state law. And PTs still get many cases from referral. However, referral is not a mandatory component of direct access anymore, as there is direct access in all 50 states. Now we have talked about patient care duties of the PT and PTA. But besides patient care, what do you think are other duties of a physical therapist? And what are other duties of a physical therapist assistant? Let's look at these duties. For the PTA, there's consultation, administration, instruction, critical inquiry, and prevention and wellness activities. For the PTA, there's equipment maintenance, assistance with administrative tasks, instruction, and critical inquiry. Examples of PT duties as it relates to consultation could be a building manager consulting with a PT to find out how to make their building more handicapped accessible. As well, with a physical therapist, they can be involved in administration, which includes administration of a PT clinic, an educational program, and such activities. You can see that both the PT and PTA are involved in instruction. This can include patient instruction as well as community instruction. So for example, you could put on a back school presentation for the local community. You can also see that the PT and PTA can be involved in critical inquiry. And this is research. This is relating back to evidence-based practice. You can see that the physical therapist is involved in prevention and wellness, in which they perform screenings and prevention activities, as well as on-site or off-site services for work-site analysis. PTA duties can include equipment maintenance and assistance with some of the administrative tasks. So besides patient care, there are several duties that the PT and PTA have. And finally, as it relates to the roles of the PT and PTA, what are the current trends? Well, for the physical therapist, there is a shift from the master's degree to the doctorate degree for the entry-level practice. In addition, for the PT, we are moving toward primary provider status, meaning the entry point into the healthcare system. As you will recall, 50 states have some form of direct access. As for the PTA, there is an advisory panel to the APTA Board of Directors. This gives input to the National Board of Directors from PTAs to apprise them of issues specific to the PTA. In addition, for the PTA, there is the possibility of recognition of advanced proficiency. This recognition of advanced proficiency can be in 4 different areas: musculoskeletal, neuromuscular, integumentary, and/or cardiopulmonary. This credential adds acknowledgement of a level of expertise. Be clear, however, that this is different than the American Board of Physical Therapy Specialty Certification for PTs, as discussed earlier. In summary, then, we discussed the roles and functions of the physical therapist and the physical therapist assistant, and we examined the boundaries between the PTA and PT in regard to education and clinical practice.